in this lecture, we are going to discuss the validity of a screening test. In the previous lectures, we have already mentioned screening and secondary prevention. Secondary prevention, which means the detection of the subclinical cases and the intervention in order to prevent the progression of the disease. The subclinical cases, they are the cases where they have no sign and symptoms. They have the pathological changes, but the patient have no sign and symptoms. So it is important to interrupt the chain of the natural history of disease by early detection and starting of the treatment in order to modify the prognosis of the disease. So screening is one of the important procedure which is performed as an aspect in the secondary prevention. So as a screening test, it is important to know how valid is the screening test, or how reliable or how accurate is the screening test. So we are going to discuss the validity of the screening test, which we are going to use in the secondary prevention. So in this lecture, we are going to discuss the validity and reliability or accuracy of a screening test. What are the components of the validity, such as the specificity and sensitivity, positive or negative predictive values, and what is how the predictive value is influenced by the prevalence. So the validity of a test. The validity is the ability of a test to measure what is intended to measure. So it expresses the ability of a screening test to separate those who have the disease from those who have no disease. So by the validity, we are going to sort those who have the disease from that who have no disease. And usually the screening test is always compared with what is called a standard test or a gold standard test in order to see whether it is valid or not. And a test with a little systematic error is a valid test. When there are a low error or small error, so the test will be valid and it can be used as a screening test. So the component of a screening of validity includes sensitivity, specificity, and predictive accuracy or predictive values. The sensitivity of a screening test. It is the ability of a screening test to correctly identify those who have the disease or true positive cases. That means the proportion of a truly ill population. So, always, as we mentioned, we are going to compare the screening test, which is on the left side, and the gold standard test. And the gold standard test, they are the tests which they are accurate and reliable, and we can compare the screening test with the gold standard test. For example, if we want to assess the ability of a doctor in the diagnosing anemia among pregnant women, so this is regarded as a screening test, and we compare it with a gold standard test, which is, for example, the level of hemoglobin. Or if we want to compare the ability of a doctor to compare or to diagnose breast cancer by physical examination, so the gold standard test is the ultrasound or the ultrasound with the biopsy. That's better. If we want to compare the ability of ultrasound as a screening test for breast mass or cancer, and we compare it with the gold standard, which is the histopathology after the removal of the lump, and it is tested whether to see whether it is malignant or cancer or not. So as you see in the table, on the red portion you can see, or the pink portion, we can see the disease in the gold standard test. The red column represent represent the individual who are positive by the standard test. That means that individual, they have the disease according to the gold standard test, while the blue column is the individual who are negative by the standard test. And if you take the first row, test positive by the screening test, and the second row is test negative by the screening test. So always we are going to perform or to make 2 by 2 table in order to compare the two tests. So always when we have any problem or statement and numbers, so then we are going to convert it into what is called 2 by 2 table. So the first column, the pink column, which is the diseased individual according to the standard test, and the blue is the negative by the standard test, while the first row, as we mentioned, for the screening test, positive and negative. So the individuals, if we are going to discuss the cells in the table, we can see that the letter A. Letter A represents the individual or group of patients who are positive by both tests, and the B, they are the individuals who are positive by the screening test, but they are negative by the standard test, while which is denoted by the letter B, while the letter C denoted to the group of people who are positive by the gold standard test, but they are negative by the screening test, and they are denoted by C, and D, they are the group of people, they are negative by both. So A, they are positive by the screening test and gold standard test. The B, they are the group who are negative by the standard test, but they are positive by the screening test. The C, the group of individuals who are positive by the standard test or having the disease according to the standard test, and the D, they are the group of people, they are negative by both. That means they have no disease by the two tests. So the A called a true positive because they are positive by both, and D, they are true negative because they are negative by both tests, while the B, they are called the false positive because according to the standard test they are negative or have no disease, but they are positive by the screening test, they are false positive, while the C, they are the group of people who are positive or having the disease according to the gold standard test, but they are negative by the screening test, so they are called the false negative. So the ability of a screening test to diagnose or to label the individual who are really diseased by the gold standard test as positive, so these are called the sensitivity. So the sensitivity is equal to those who are true positive by both divided by the total positive by the gold standard test. So the sensitivity equal to true positive, which is A, and divided to the total positive by the gold standard, which are they are A and C. So this is the sensitivity, and always it is expressed as a percentage. So the ability of the test, the screening test, to correctly diagnose individual as diseased from those who are diseased who are actually diseased by the standard test. This is called the sensitivity. They are the sensitivity is the ability of the test to correctly diagnose or correctly labeled individual as diseased or having a positive finding from those who are having the disease according to the gold standard test. Sensitivity, so it's the proportion of people with the disease in the screened population who are identified as ill by the screening test, or the ability of a test to correctly identify a true diseased persons, and it is also called the true positive rate. When the disease is present, so how often does the test detect it? This is the meaning of the sensitivity. When the disease is present, how often the screening test can detect it and label individuals that they are diseased. The validity of a screening test is assessed against the result, as we mentioned, of a test which is which is more accurate, and is called the gold standard test or reference test or validating test. So the screening test may be specific question, or a physical examination, or a procedure, or a laboratory test, or other methods intended to identify and recognize disease. So the screening test, it is not necessarily to be a laboratory test, but it may be a physical examination, as we mentioned in the previous lecture. Physical examination such as the blood pressure, or the physical sign for anemia, or for measuring the hearing assessment. So can be physical examination, or it can be a test. So we can measure the ability of a doctor in the diagnosing hearing or vision problem among school children by physical examination. This is what is called the screening test, and the gold standard test is the audiogram. So we compare it with the audiogram. So the sensitivity is the true positive, which is A, and divided by the true positive plus the false negative, which is A and C multiplied by 100. The false negative rate, if you can see from the table before, the false negative rate, which is C, it can be calculated by just 100 minus the sensitivity. 100 minus sensitivity, or we can calculate it from the table that it is false negative, the C, divided by the total true positive plus the false negative, which are the diseased individual. While this specificity is the ability of a screening test to correctly identify those who do not have the disease. So this is called the true negatives. So the specificity is the ability of the test, a screening test, to correctly exclude the disease among individuals who have no disease. That means the screening test show negative result among those who are actually not having the disease, and this is called the true negative. So the proportion of a truly healthy population. And according to the table, we can see that the specificity equal to the actual or true positive, which is denoted in the table as the true negative, which is denoted in the table as D, and it is divided by the total negative. True negative plus the false positive multiplied by 100. So the specificity equal to the true negative, which is D, divided by true negative plus the false positive multiplied by 100. So the specificity is the ability of the test to exclude those who have no disease from those who are having no disease according to the gold standard test. And the false positive rate, which is B, is equal to 100 minus specificity, or it is equal to the B, which is the false positive divided by the true negative plus the false positive, which is B and D. So the false negatives individual. What is the significance or what are the implications of an individual who have no disease but according to the screening test is diagnosed as having the disease? The false negative, they are the people or the individuals who have a disease and labeled as negative. False negative individual who have the disease by the gold standard test, but according to the screening test, they are labeled as have no disease. So, what are the significance of such a problem? Such individual, he have false reassurance. So we are going to reassure him that you have no disease according to the screening test, but actually they have disease. So such individual will ignore any disease disease sign or symptoms, or postponement of a treatment. They will not have appropriate treatment or essential treatment, or this will affect his it will affect the overall health. For example, we denoted that this individual have no disease, but actually they have a disease. So this is cause underestimation of morbidity in the community or in the population. Also, the disease may be fatal, or it is infectious or communicable, so he can transmit the infection to other. Or if he have a severe disease or fatal disease, he may have complications. So we are labeled him as healthy individual, but actually he has the disease. So these are the importance or the significance or implications of an individual who have a disease, but we label them by screening test as they are free of disease. While on the other hand, the false positive individuals, they are individuals who have no disease according to the standard test, but they are labeled as having the disease according to the screening test. So what are the implications of such a false positive? We may refer him for further tests, which may be expensive, or it need time consuming at the healthcare services, or it may be painful, and they are unnecessary tests. So if an individual he is false positive, according to the screening test, we labeled him as having the disease. So we are going to refer him for confirmation of a test, another test for confirmation. So he will have further testing, which may be painful, which may be expensive, time consuming, and also it cause discomfort for the patient and inconvenience and anxiety for him. We cause psychological trauma or anxiety for the patient by labeling him as diseased, and actually he have no disease. Also, the burden on health facilities. So it is costly for the health facilities and for the patient, and emotional trauma, and it is sometimes difficult in delabeling. When you label an individual and when you tell him that you have a disease, so it is difficult to take this idea from him and telling him that no, you have no disease. So it is important to be very important in the screening. The false negatives, it comes on the test who have low sensitivity but high specificity, while the false positive, it comes from high sensitivity and low specificity. So this table just to show you the details what we have already discussed, and the formula of each, which is already, it is repetitive for what we have already discussed. The overall agreement rate. The overall agreement rate, they are the rates of those which is equal to the positive by both and negative, positive by both plus negative by both and divided by the grand total multiplied by 100. That means those who are positive by the screening test and the standard test, which is called the A, denoted as A, which is a true positive and true negative, divided by the grand total. So the overall agreement rate, or some books mentioned as repeatability, is the true positive plus the true negative, or positive by both, which is A, negative by both, divided by the grand total, or the total. So it multiplied by 100. So A plus D divided by A plus B plus C plus D multiplied by 100. The misclassification rate equal to false negative plus false positive multiplied or divided by the grand total, and multiplied by 100. The sensitivity and the specificity rate characteristics of the test and are only influenced by the test characteristic and the criterion of positivity that is selected. Predictive accuracy or predictive values. When evaluating the feasibility of the success of a screening program, one should also consider the positive and negative predictive values. These are also computed from the 2x2 table, but the perspective is entirely different. So, in the sensitivity and the specificity, when we calculate the sensitivity or specificity, we are going to take the columns. While in the predictive values, we are going to calculate the positive or negative predictive value from rows. So the predictive value, the positive predictive value, is the probability that subjects with a positive screening test truly have the disease. What does that mean? That means that those individuals who are by the screening test, they are positive, how truly they are having the disease from the in the community. That means we are going to calculate the predictive value from the rows. So the positive predictive value is the probability that subject with a positive screening test truly have the disease, while the negative predictive value is the probability that a subject with a negative screening test truly they don't have the disease. So the positive predictive value of a test is very dependent on the prevalence of the disease in the population being tested. The higher the prevalence of the disease in the population being screened, the higher the positive predictive value. The specificity and the sensitivity, they are not affected by the prevalence of the disease, while the predictive value is dependent on the prevalence of the disease. So, when thinking about the predictive value of a test, imagine that you are a physician and discussing the results of a screening test with the patient. So, if a test was positive, so that means how likely is it that he really has the disease? How worried should be he? That mean if the individual have positive predictive value or the positive predictive value of a screening test, it means that how the individual will worry about the occurrence or the presence of the disease. While the negative predictive value, how likely is that he is really does not have the disease, and how reassured should be he. So the positive predictive value equal to the true positive, or the A, which is positive by both, plus the A plus B. Sorry. So the positive predictive value equal to A, which is the actual positive or true positive by both, divided by A, the true positive, plus B, which is the negative by the standard, but it is positive by the screening test, which is B. So the positive predictive value equal to A, the true positive, plus divided by the true positive, plus the false negative. While the negative predictive value, it is it equal to the D, which is the true negative, divided by C, which is false positive, plus D, which is the true negative. Let us have an example. In a study carried out to evaluate the ability of a doctor in the antenatal care to detect anemia in pregnancy among users of the healthcare services. We want to assess the ability of a doctor in the antenatal care to diagnose anemia by physical examination. And the validity of a test or the standard is the hemoglobin level by laboratory test. The valid test or the reference test or the standard test is the level of hemoglobin by laboratory test. So in this study, it involved 800 pregnant women, and the results were as follows. Of these 800 pregnant women, 440 were considered anemic, according to the as a result, out of the 800 pregnant women, 440 were considered anemic by the laboratory test. According to the standard test, the positive or diagnosed anemic by the standard test, they are 440. This is the standard. Of the anemic group, from this 440, according to the laboratory test, the doctor in the antenatal care or the screening test were able to identify 230 as anemic. And in addition, they labeled 55 of the non-anemic as anemic. So, as a doctor, according to the hemoglobin level, laboratory test or the standard test, 440 were having anemia or positive by the standard test. As a doctor, he is able to diagnose only 230 women as anemic from those who are diagnosed anemic according to the hemoglobin. Out of 440, he diagnosed 230 as anemic. And also, he is able to label 55 of the non-anemic as anemic. So, how accurate or valid was the judgment of the doctor in the antenatal care in detecting anemia among pregnant women? So, the first thing to answer the question, we are going to perform or construct 2 by 2 table. So, according to the standard test, from this table we can see that according to the standard test, the laboratory test, we have positive, we have negative, and the screening test or the antenatal care, we have the rows, positive and negative. So, according to the laboratory test, the positive individual 440, according to the hemoglobin level. And the individual, the doctor, so the 440, they are the positive. So, how many individuals have no anemia according to the standard? We are going to construct the those who have the total 800 minus 440. So the remaining are 360. They have no anemia according to the standard test. The total are 800, while the doctor the hemoglobin the hemoglobin level or by laboratory test 440, they are diagnosed as anemic. Okay, so according to the standard test, those individuals who have negative or have normal hemoglobin level, they are 360 by taking the by 800 minus 440. So 360, they have negative or they are normal, having no anemia according to the hemoglobin level. These are about the columns, while the rows they are the results of the screening test. So according to the screening test, out of the 440 positive by the standard test, the doctor able to truly labeled 230 as having anemia according to doctor examination. So out of the 440 who are positive by the gold standard test, only 230 they are labeled as anemic by the doctor. So this is called the true positive. And also he labeled as 55 as they have no anemia. So the 55, according to the doctor, he labeled them as they labeled him as anemia, as anemic, and actually by the standard test they have no anemia. So as antenatal care doctor, he was able to correctly diagnose anemia among only 230 out of the 440, while he labeled 55 women who have no anemia according to the standard test, but he labeled them as anemic. So this is the false positive. False positive, they are positive by the standard test, but they are negative. They are positive by the screening test, but they are negative by the standard test. So the remaining, so then we are going to construct the table and complete it, put the numbers in different cells. So 230, they are true positive, positive by both. The 55 is positive by the screening test, but they are negative according to the standard, so they are false positive. And the 210, they are false negative because they are positive by the standard but negative by the screening test, so they are false negative. And the 305, they are negative by both, which they are D. So accordingly, the total anemic by the laboratory test, as we mentioned, 440. The antenatal care doctor identified 230, the A. So they agree on A. Both they diagnose as anemic by the two tests. So the sensitivity equal to the A, which it is positive by both, divided by those who are positive by the standard test, which is 440, which include the A and C, divided by 100, so the sensitivity equal to 52%, nearly 52%. So as a doctor, he is have low sensitivity in screening the pregnant women, have low sensitivity, so he is less likely to diagnose anemic among anemic women. So this means when the sensitivity is 52%, so the doctor is sensitive only, or he is able only to diagnose anemia in 52 cases of anemia among pregnant women. So the 52 represent the ability of the antenatal care to diagnose only 52% of anemia among those who have anemia. So while the specificity equal to the true negative, which is D 305 divided by the 360, which include the B plus D, which is the true negative, true negative D plus the B, which is the false positive, multiplied by 100, which equal to nearly 85%. This means that the doctor is able to exclude anemia among non-anemic. He is able to exclude anemia among those who have no to exclude anemia or labeled individuals of having no anemia and they have no anemia according to the standard test. So the positive predictive value we mentioned, we calculated by the row. How many positive, truly positive, from those who are diagnosed positive by the screening test. So the predictive value, positive predictive value, equal to the true positive A divided by the total positive by the screening test, which is A plus B, and equal to 80%. And that means among those who had a positive screening test, the probability of the disease was nearly 81%. While the negative predictive value equal to the true negative, which is D, divided by those who are negative by the screening test, which is equal to C plus D, and equal to 305 divided by, from the table, 515, and multiplied by 100, equal to 55%. That means among those who had a negative screening test, the probability of not having the disease was nearly 59%. And the overall agreement rate, we mentioned that is the positive by both, or the true positive, 230, plus negative by both, which is 305, multiplied by 100 divided by 800, and equal to nearly 67%. So while the overall misclassification test is the true positive plus the true negative divided by the grand total, so it is 210 plus 55 multiplied 100 divided by 800, and equal to 33%. So the overall misclassification rate is only 1/3 of cases. So for the abbreviation of this, or we have some notes, important notes, which include sensitivity and specificity do not change with the change of the prevalence of the disease, but do change with the changing of the cutoff point between normal and abnormal, and we are going to discuss that. The cutoff point means at what level we regard the individual positive or negative. And this is used in those which we have what is called continuous data. We have to put cutoff point, for example, at what level we can regard the individual diabetic or not diabetic. and this is depend on the or according to different studies. Either we rely on the for example on the level of the glucose tolerance test, or on the random sugar test. So if we take as a reference the glucose tolerance test, so everyone who is above 120 regarded as diabetic, less than that non-diabetic. So there should be a cutoff point, a level at which we regard the individual having the disease or not having the disease. That is called the cutoff point. So the sensitivity and specificity, they do not change with the prevalence but with the cutoff point. At what point you are saying that this individual anemic or not anemic. So this is according to the age and to the sex of the individual. So for example, 12 regarded as normal, less than 12 regarded abnormal, and it is different according to the country, to the culture, to the sex, to the environmental, or to the diet. So but it is sometimes it differs from one country to another. Any screening test is highly preferable to have high sensitivity and high specificity to avoid the misclassification of screened people, and we have already discussed the implication or the drawback of classified individual, whether having disease or not having the disease. A highly sensitive test is required for the screening of fatal disease and highly communicable disease to avoid missing any case. So, in a disease who is a fatal disease or serious disease or communicable disease, we need to have a highly sensitive test. We don't want to miss any case. So it is important to have a highly sensitive test is required for the screening test. We don't want to miss any case. We don't want false negative. We don't want false negative as much as possible from this fatal disease or communicable disease, because we don't want to miss any case. Sometimes some diseases it need immediate treatment, and this may change the prognosis of the disease, or it need immediate intervention. So it is important to diagnose disease, and even if we have, and we don't want to miss any case by labeling them as false negative, that you don't have disease. For example, in the myocardial infarction, if we label the individual as false negative, that we tell him that you don't have a disease, and actually we miss him. So he will die soon if he doesn't have a immediate treatment or early intervention. While for a disease which is fairly common, non-fatal disease, for example in diabetes, a common disease and non-fatal, we need a highly specific test, because this disease is, as a diabetes, it is a long-term disease, a chronic disease, and it needs long time for the development of complication. So even if we miss one or some of the cases, so it doesn't matter. It will be picked at another time. So if we labeled the individual as not having diabetes, and he is actually not having diabetes, so this will not affect him because it needs long time. But if we label him as having diabetes and he is not, so he will go and have he will have another test. He will start a treatment sometimes which is not needed. But a fairly common disease and non-fatal, we need highly specific, because we don't want to increase the number of false positive, which they will go and they consult a hospital and they will do further tests, and this will be expensive for the patient and for the healthcare. The concept of cutoff point, as I mentioned, it is unlike the bimodal distribution or dichotomous data. Some diseases comes in continuous variable, or for example, as we mentioned, in diabetes, for the glucose level, blood sugar, or the hypertension, or the other hypertension, which is, for example, we examine the if we measure the blood pressure, for example, 140/90. So these numbers, what is called, it is continuous number. So it is important to put a cutoff point at which we are going to decide whether the individual hypertensive or not. For example, for the systolic or for the diastolic. For the systolic, 140 is regarded above 140 is regarded hypertensive, below 140 regarded as normal. And for the diastolic, the 80 is the cutoff point. So always there is a cutoff point. In these cases, it is difficult to calculate sensitivity and specificity. So cutoff point must be set to distinguish between positive and negative result. So if we have, for example, if we take the diabetic and non-diabetic individuals, diabetic according to the, for example, the glucose tolerance test, and negative according to the glucose tolerance test. So at what level we can set the values to see that they are positive or they are negative. So if we consider 20 diabetics and 20 non-diabetics screen using a blood sugar test in vertical axis from low to high. So for the low cutoff point, we can see if we put the low cutoff point, so that means we are going to put the blood sugar level, and this will result in a sensitivity of 85% while specificity in 20%. So the false positive originate more non-diabetic and diagnosed positively. So it is important to have high specificity rather than high sensitivity, because this will result in high positive test. While if we put a high cutoff point, so the sensitivity will be 25 and the specificity 90%. So the false negative originate here. False negative originate, so more diabetic are not diagnosed positively. So different cutoff point, different sensitivities and specificities. The cutoff point that identifies more true negative will also identify more false negatives. The cutoff point that identify more true positive will also identify more false positive. So the choice of a high or low cutoff level for a screening therefore depends on the importance we attach to the false positives or the false negative. In case of a lethal disease, as we mentioned, early intervention possible, cutoff point must be set at a low level as greater sensitivity is required. False positive can be tolerated. So this is another example for how to calculate the sensitivity and the specificity. It is the same steps which we have already mentioned previously. It is just for elaboration for the how are we going to calculate the different values. Reliability, as we mentioned, reliability determines the precision of the test, or repeatability, as we mentioned. It means that all the results of the test should be similar, cluster at one place. So similar results with from similar tests in other places or different studies. So how much we repeat the test, it will give the same result. So this is not possible because of the variation, and that causes the test to not yield same result every time, like laboratory equipment or failure, or there are certain factors which affect the results of a test. And these variation which result either maybe from intra-subject variation, in the subject himself and the patient himself, variation in the individual himself. For example, when we measure the blood pressure in the morning and the evening and the afternoon, so there will be variation in there are certain factors which affect the value of a blood pressure or the blood sugar, for example. Or intra-observer, which is the difference between different, or variation between different observer, or sorry, intra-observer variation. This is the intra-observer, by or the variation in the individual himself. While the other one, this is the inter-observer, sorry, the last one is the inter-observer rather than the intra-observer. So there are three types of variation: intra-subject variation, the variation in the subject himself and the patient himself, and there are different causes for variation. Or intra-observer, which are the variation among the observer himself when he measure the patient, but he have different readings. Or inter-observer, between two or more observers. So the intra-subject variation, this variation in the results of the test or measurements, if it is conducted over time or short period on the same individual. This, for example, variation in the blood pressure during the first 24 hours, or during the day or during the 24 hours. So the intra-subject variation is the variation among the subject himself. If we measure the blood pressure during the day, we can see different measures. While the intra-observer variation, the variation and the result of the test due to the same observer, the same doctor or the same observer, when he examine patient, the same patient, he give different result. So two readings of a blood pressure by the same observer. While the inter-observer, the variation between two observer, this is the variation in the results of the test due to the multiple observers examining the result. For example, chest x-ray read by two different radiologists. This is an exercise for yourself to practice yourself how to construct a 2x2 table and how to calculate the validity of a screening test and give your interpretation. So from this lecture, we have already discussed the screen, and we mentioned that the screening, despite its flow, is a major public determinant measured by its effect on mortality, morbidity, and disability. And also establishing appropriate criteria requires considerable knowledge of natural history of the disease, adequate facilities for follow-up and treatment, and it is necessary to ensure that the program is continuously monitored to confirm that effectiveness is maintained, that the benefit more than the cost. And in newer fields such as genetic screening are on the rise, which would help the cause. And thank you.